Good morning, respected sir and my dear friends. Today we are going to discuss about some of the important blood culture isolates that we got in the last 1 week. So this is the first case. It's a 67-year-old female diagnosed to have invasive ductal carcinoma, right breast, Birad's 5 stage and left breast with Birad's 1 and the American Joint Committee on Cancer staging T4B N1M0. That means T4B means the entire breast areola, skin and chest wall involvement is there, and N1 means that right axillary lymph node involvement is there, and M0 means no distant metastasis detected. And she had a history of diabetes mellitus on OHA for last 12 years and hypertension also on medication. So after the diagnosis of this invasive ductal carcinoma, that markers was also sent, which was ER/PR positive and HER2 negative with a Ki67, that is a proliferative index of 50 to 60%. That means it is a type B intraluminal ductal carcinoma of the breast. So for that they have done 4 cycles of DDAC, that means adriamycin and cyclophosphamide regimen first. 4 cycles, that means every 2 weeks they have repeated the same thing. That means adriamycin 6 mg per meter square and cyclophosphamide 600 mg per meter square. After that they had started on taxane based regimen, that is a paclitaxel. That is also 4 cycles. That means total 8 cycles they have planned. After that they are planning for surgery of this case. So after the 3rd cycle of taxane, that is an antimicrotubule inhibitor, that is a paclitaxel, she developed fever, dry cough, weakness and loose stools for 3 days duration. For this presenting complaint, she came to our hospital for this evaluation and got admitted. So during admission, if we are looking at the oral cavity of the patient, it is having glossitis and you can see a white patch on the oral cavity, that is suggestive of oral candidiasis also in this case. These are the blood parameters during admission. So January 2nd she got admitted. The total count you can see it is 17,700 with a neutrophilic leukocyte ratio of 34 to 56 and ANC of 0.60, hemoglobin of 9 and procal level of 48.8. They have checked procal because she is having fever spikes and all the symptoms. So this patient is on chemo. We cannot predict from the CBC parameters because some bone marrow suppression will be there due to the chemotherapeutic agents. So after admission you can see the count got gradually increased. Why? Because after the admission they had sent the basic investigation, CBC, blood culture, urine culture and other basic investigation like is RFT, LFT and all. So and along with that they have started this patient with the filgrastim. Filgrastim, that is 300 micrograms subcutaneously every day they are giving because the count will be decreased, the neutrophil will be also low, there is a higher chance of infection in the patient. So they have started filgrastim also. So you can see the progressive increase in the counts. So along with that all the investigation they have sent the blood culture also. This is a study showing the effectiveness of pegylated filgrastim, that is like pegylated interferon. This filgrastim weekly we have to give, or every 5 days we have to give in this chemotherapeutic patient taking chemotherapeutic agent. So this pegylated means every 8 day or 9 day only single dose is sufficient. So it will be more effective. Here we are giving filgrastim only. So they have started, after taking blood culture and other investigation, they have started empirically this patient because patient is having high risk, the counts are low, absolute neutrophil count is also low. They have started with higher end antibiotics like IV, meropenem 1 gram, extended infusion. They have particularly written in their file, that's why I included, that means how to give extended infusion, everything pakka they have written and given to this patient. Meropenem 1 gram IV TDS over 3 hours and filgrastim also they have given 300 micrograms subcutaneously along with linezolid 600 mg 8 hourly. And they have started this patient on TAP fluconazole 200 mg OD along with candid mouth pain TDS for this oral candidiasis parameters. So blood culture of this patient, 2 blood culture bottle flagged which shows the presence of MRSA. So when we are looking at the BMQ bar MIC of this isolate, teicoplanin it is more, it is 16. But we informed them, but they have already started on linezolid. And one more thing is there, they continued linezolid because this patient is having some respiratory association is also there. Patient is having cough and some consolidative patches are there, but it is not increasing. So for lung infection, better than teicoplanin, we all know that is linezolid and vancomycin will be better. So they continued this patient with the linezolid because they already started. So they continued the same regimen along with the fluconazole. So this is the IDSA 2016 management of hospital-acquired pneumonia caused by Staph aureus and MRSA. So in MRSA isolates, it is better to give vancomycin or linezolid based regimen rather than teicoplanin according to the penetration in the lung tissue. So what is the outcome and what is next plan? So we all know if a patient in blood culture we are getting Staphylococcus aureus or MRSA or Candida, definitely we have to do the cardiovascular system examination if any new onset murmur is there, and also we have to rule out any infective endocarditis focus is there in this case. So this patient also they have done echo. Currently they have done the transthoracic echo only. That echo shows no vegetation, ejection fraction is more than 55, nothing is there, flow is okay, but actually, if it is persisting, they are planning for transesophageal echo of this case. So after this blood culture become negativity only, they have to start the fourth cycle of paclitaxel in this case. This case actually it is MRSA. It's an oncology ward. So after getting this MRSA, the patient got isolated in a separate cubicle and they are taking all these contact precautions including chlorhexidine body wash they are using for this case. So this is the role of echocardiography in case of Staph aureus and MRSA. That means it was a study conducted and more than 400 cases. That means in Staph aureus and MRSA sepsis, if you are doing an echo, the morbidity and mortality of this case can be reduced in a high percentage. So this is the thing we have observed in this case. It's a high risk patient with an absolute neutrophil count is also low with a high chance of infection. So they have treated with this patient with started empirically with higher end antibiotics due to higher risk factors, and along with the filgrastim, the patient clinically improved, and now also they have sent the repeat culture. We have to monitor when it becomes negative and follow up this case. So next case, this is a 47-year-old male. He is having a walk along with this fish catching and all along with the sea, and he is having a type 2 diabetes mellitus history of 25 years on voglibos, metformin and glimepiride, but not adherent to medication properly. And he presented to the surgery ward, surgery OPD with bilateral cellulitis with a chronic ulcer on the right foot for 3 years. For that multiple times he is going to outside hospital, doing dressing and taking some antibiotics, but it is not properly resolved. But during the examination in our hospital, it's showing some granulation tissue, but it's healing like thing is seen on the right base of the foot, and but having bilateral cellulitis. And he was a chronic smoker and alcoholic, having this vascular disease, peripheral obstructive vascular disease is also shown. This is the first day picture having cellulitis, and you can see the right foot one ulcer is there, left big toe also one ulcer is there. This is one more picture. So these are the complete blood count picture of this patient during admission day. Total count was raised, that is 22,000 with a neutrophilic predominance of 71%, and absolute neutrophil count also raised, that is 16%, and the procal also 28 and CRP also 140. These markers you can use for prognosis, but they have done in the first day, that's why I included. So this case pakka cellulitis case, though they started piperacillin, tazobactam and clindamycin to this patient on the first day of illness, along with glycerin mux sulfate, dressing of the bilateral cellulitis and the proper wound care of the right foot ulcer. So they had sent the blood culture of this case. We got Streptococcus pyogenes from the blood culture. So you can see there is a clindamycin resistance in the antibiotic sensitivity pattern, And we have reported the other thing, that is ampicillin sensitive, cefotaxime, penicillin and all sensitive. So they continued the same regimen, piperacillin, tazobactam and clindamycin to the patient. So I have searched some literature. Even though the clindamycin shows in vitro resistance, we can use for treatment. Why? Because clindamycin mechanism of resistance we know, that is a protein synthesis inhibitor, that is 50S ribosomal inhibition. So it can be used for two aspects, because the toxin production also get reduced by giving clindamycin. So even though which is in vitro resistance, not monotherapy is recommended. We have to combine with other beta-lactam agent or the piptazolate combination we can give in this case of resistance. So this is an article. So it's a 10-year study with group A bacteremia with clindamycin resistance. It is done by Dr. Niyas and Dr. Rajalakshmi from KIMS Hospital, Trivandrum. It's a 10-year study. So 25% of their isolate shows clindamycin resistance, but in vivo, the combination therapy, they shows better effect in this patients. So in our patient also, they had continued with the piperacillin and clindamycin and local care with proper glycemic control. This case, it's not adherent to proper medication at all. 25 years of this diabetes mellitus is there, and CKD parameter is also there, diabetic retinopathy is also there. All the complication of diabetes is in this patient is present. So they are continuing with that diabetic management along with the wound management of this case. And they have repeated blood culture, but that didn't flag it. And yesterday I saw this case that wound granulation tissue is there, sir, but some slough is there in that edges. So they had sent that for culture also from that particular right foot ulcer to rule out any other organism is also there causing this sepsis in this case. That's about the second case. Next is the third case. Third case is actually a very different case. That is a 43-year-old male. In his 12 year of age, he had presented with multiple warty lesions over the lower limb initially at the age of 12 years. And then it progressed. Throughout the body, black color nodular lesions appear throughout the body with hyperkeratosis of the both upper limb and lower limb. So now he presented 2 months back with in between fever episodes along with cough and tiredness only he had presented to initially. So during that time, thorough investigation was done to rule out why he is having these fever episodes. That time during examination, they had found out right inguinal lymphadenopathy in this case. And all this HRCT, everything was done, which was also subcarinal lymph node enlargement. So from that, they have sent this endobronchial ultrasound and the bronchial aspirate for this patient, and they have detected non-Hodgkin's lymphoma of this case from this inguinal lymph node and this subcarinal aspirate of bronchoscopic specimen. So this is actually a case of epidermodysplasia verruciformis. It is an autosomal recessive condition. That means during adolescence or at the age of 17 or 18 years, only the patient may present with this condition. And it is having an association with the human papilloma virus 5, 14, 17 and 18 strains also. So this patient have a history of this epidermolysis verruciformis, now diagnosed to have NHL part, but that NHL part one confusion is there. They had initially sent one biopsy to our center, they are telling it is NHL. So second time during this endobronchial ultrasound and the biopsy aspirate, they had sent outside also. So they are telling it is just a lymphadenopathy only, nothing more than NHL. So they didn't start any treatment for this case. So finally, before 5 days, the patient presented with the severe sepsis, MODS, severe acidosis, and patient got ventilated, increased count, and it's very difficult to manage. The patient actually succumbed to death with this multiple risk factors. So this is this lesion seen in epidermolysis verruciformis lesions. This is our patient. You can see multiple nodular lesion with hyperkerotic patch. It started at the age of 12 years. Now the patient is 47 years. But this case, for this particular illness, he didn't take any medications, nothing he had done for this particular thing. Literature also is telling that if some patient is having this type of lesions, the exposure to sunlight they have to avoid the squamous cell carcinoma and other complication in the future, and they have to use some sunscreens or some steroid preparation if it is needed. Otherwise, no particular treatment for this condition. And this patient, during the sepsis and MODS, it is very difficult to manage means that acidosis is one part. Definitely the next arm of this complicated part is HLH, that is hemophagocytic lymphohistiocytosis. So this ferritin is increased, platelets, pancytopenia is there, and the other hepatosplenomegaly is there. They have done the bone marrow aspiration in the MIC also, which shows the here this histiocytes in this bone marrow biopsy also. So 5 out of 8 criteria, if it is there, we have to fit it, which should be fit into HLH. So this case also fit into HLH criteria. So in HLH, during dengue discussion I have described, dengue only one condition we have to start with steroids, that is HLH. Like that this patient is having HLH with severe sepsis, they have added steroids also to treat and save this patient. They have started the antibiotic meropenem, clindamycin along with steroid as the patient is having HLH part also. Platelet count is bicytopenia is there. HB was 5, platelet count was 25,000 only. So empirically started with Miro, Clinda, dexamethasone 1 mg per kg, that is 60 mg they have given, and blood culture they have sent for this patient. It got flagged after 2 days. In the gram stain you can see gram negative bacilli. In the culture plate we got some non-lactose fermenting cholangiosine, yesterday's culture plate, but MALDI was done for this isolate. We got Serratia marcescens for this particular isolate identification. Today we have to check this pigment production after 48 hours, and a pigment came or not, we have to check. So I just included this from M100 CLSA because the Serratia, when we are treating some intrinsic resistance, we have to be thinking of. Every isolate should be that particular thing we have to think. Here you can see the polymixing group, nitrofurantoin, first and second cephalosporin, these all are resistant. But this case they have started with meropenem, the direct susceptibility pattern also, which is showing sensitivity to meropenem. But unfortunately, due to the other parameters like MODS, severe acidosis and HLH, the patient succumbed to death. So this is a case of one autosomal recessive condition with non-Hodgkin's lymphoma with presented with a sepsis with a serratia. So serratia sepsis cases are rare, mainly some skin and soft tissue infection, prostatitis, UTA. So total 8 cases of skin and soft tissue infection with the serratia only I saw in the literature. So mainly UTA, prostatitis cases. BSI will be rare. But why this patient got serratia in the blood? That is another question. So he had done 2 times this inguinal lymph node biopsy and these things are done. So some invasive procedure and bone marrow aspiration was also done. During some procedure, or we don't know, the organism get inside this patient. Steroids is also there, sir.
It could be a gut transmigration also.
Yes, sir. So this is the case. Both blood cultures we got this serratia. So this is a 242 cases with a retrospective study which shows epidemiology, resistance profile and risk factors associated with the MDR serratia. That means serratia in our isolate also, which was ciprofloxacin resistant. So it is an oral option. We can give fluoroquinolone based therapy if it's a UTA or other cases, but that resistance is also emerging. So they are telling, compared to the levofloxacin part, Cipro is having less resistance in serratia isolates in this 242 cases of retrospective study of serratia marcescens causing infection. It is not only this bloodstream infection, they have included the other samples also, UTI, prostatitis, all this skin and soft tissue infection, all samples they have included in this particular study. So other resistance, when we compare the other antibiotics, the quinolones have less percentage of resistance detected. This is another case. Actually this patient, it is having 25-year-old male with a history of hypertension for the last 2 years on telmisartan. He had an accident 5 months back, road traffic accident only. That time humerus fracture was occurred. So that surgery was done, plate was fixed. So after 2 months back he is having severe pain at the implant site. For that he came to our hospital. They had done the radiological investigation which shows some implant failure and related infection. For that they have planned surgery, and the surgery was done on 31st of December. So they have started on cefuroxime postoperatively and continue cefuroxime and gentamicin for this case. After 2 days of surgery, he got multiple fever spikes, somewhat elevated count and CRP of 223. So that time they had sent blood culture of this case. So we got, after 2 days initially we got blood culture positivity of this case, and it was actually Salmonella typhi, which is pan susceptible only. So we informed that particular ortho PG and the consultant regarding this patient is having Salmonella typhi bloodstream infection. Henry fever is there. So we asked the history of the patient. He had a travel history to Tirupati 1 month back. Other than no other GI symptom, nothing was there in this case. So preliminary, it's a humerus fracture, implant failure, reoperated case only. So we informed, but they are not convincing. When we are telling, they are telling no. We have to continue cefuroxime only because there is no other features of Henry fever like that. So then again, they are suspicious. So they again send one more bottle. One set of bottle for blood culture. That flagged the same day evening. So we got the same isolate state, same susceptibility. That time only they convinced and they discharged the patient on the same day. And one good thing regarding this patient is this patient elder brother is a doctor by profession. So they had started injection ceftriaxone 2 gram IV BD in their home only. So this part I focus more because the convincing part, the treating physicians, because they are orthopedicians, they are telling about we are giving cefuroxime, it is okay, it is good, patient is not having fever spikes after cefuroxime and gentamicin. Why we have to start this patient on ceftriaxone? We have a plan to discharge like that. So finally they are convinced because they are against and the blood culture comes positive. Patient discharged, he is taking from his home, that's IV ceftriaxone. Today he will come for review. So this case, so after the importance of discussion with the clinicians, because if you are getting something, sir is so good, sir always will message them and communicate with them. In that way, we also have to follow that clinicians and the JRs or SRs who are concerned, we have to go and talk with them. If they are not convincing, our sir will definitely communicate. That part also I think, but fortunately this case managed well. And today he will come for review. So next case actually, 75-year-old male with a history of diabetes mellitus and hypertension, diabetes on OHA for last 20 years, presented with some indirect inguinal hernia perforation, laparotomy plus resection of 10 cm ileum containing perforation with end-to-end anastomosis with intraperitoneal defect closure of bilateral inguinal hernia with peritoneal lavage for left perforated direct inguinal hernia with peritonitis, systemic hypertension, diabetes and all CVA. So this was a complicated case, that is abdominal perforation was there, so many risk factors of that patient was there. So they have done some this mesh repair to this case actually. So this patient, intraoperatively they had sent the pus sample for culture. So we got Escherichia coli, which was ESBL and AIIMS co-producer. So that time postoperatively they had given this patient meropenem 1 gram IV TDS with metronidazole, and the patient had history of TPN, total parenteral nutrition. So they had prophylactically they had added fluconazole 200 mg for this patient also from the initial thing. So after that they had sent blood culture. Blood culture we got Morganella, and this was a plate and this was a wound site of this patient. It was taken last day, and Morganella we had reported from this blood culture. So in that time we can see in that culture report Morganella and Acinetobacter baumannii was also there in that first blood culture itself. So we had reported Morganella morganii and which was susceptible to meropenem. So they had continued that meropenem metronidazole fluconazole therapy to this case. So after 15 days of meropenem based therapy, they stopped meropenem and they restarted on piperacillin tazobactam. Again also the patient is having fever spikes. They have repeated the blood culture. We again got the same thing, that is Morganella and crab from the blood culture yesterday. And the patient had undergone tracheostomy. The patient is here for more than 30 days in SICU. Tracheostomy was also done. The tracheal secretion was also sent for culture. Yesterday we got Stenotrophomonas maltophilia from the tracheal aspirate. But when we are thinking about if it is relevant or not, we have to look for the CPA score of this patient to rule out any we have to treat some antibiotics in this case. This is Acinetobacter baumannii. Yesterday we have reported from the blood culture which was crab isolate only. So this is a Stenotrophomonas. The patient is on tracheostomy. This is a latest X-ray of the patient. Previous also there is no infiltrates on chest X-ray. Counts are also on decreasing trend of this case because initially the counts was on 20,000, 22,000 like that. Now the count is decreasing trend. It is around 12,000 with a neutrophilic predominance of 70%. So this case they didn't consider this stenotrophomonas part. They are continuing giving this meropenem. This after starting piptas also fever spikes was there. Again they have restarted meropenem metronidazole. But if you are thinking about mero and metronidazole, they are giving double coverage to this case. So they are giving these two along with fluconazole for this case and this proper wound dressing of this case. But that wound is looking somewhat oozing is there. That picture you can see some oozing is there in this particular side. It's post-operative day 36 or 37 in this case. So that side, the Morganella where he got means mainly from that wound site maybe. So yesterday they have sent one, during dressing they have sent one swab from that particular site also for culture. Initially we got Escherichia coli, that was intraoperative specimen only. Urine culture was also sent in this case but no growth in urine culture. So this patient which is now also on meropenem, metronidazole and fluconazole with proper wound care is now also in SICU. This stenotrophomonas they are not taking as a pathogen in this case due to the CPA scoring and X-ray and clinical parameters. This is a systematic review and meta-analysis of the global prevalence of quinolone resistant Morganella morgani cases. So Morganella, our isolates also you can see this ciprofloxacin resistance is there. So it's a good oral option. If the patient is improving with IV, we can taper to oral regimen. But most of these cases now, this Morganella infection, this resistance of quinolones is also detected in various studies. This is another case. A 61-year-old female. Yesterday only this patient blood culture flagged positive. So I went to medicine ward. The patient was there. She had 4 months, for the last 4 months, she is having in-between fever spikes. That is PU under evaluation case. So during taking the history, she had a valve replacement surgery in the year of 2024 April. So from outside hospital it was done, aortic valve replacement due to severe AR and that trivial MR was there in that 2024. After 6 months of that valve replacement surgery, again she got multiple fever episodes and admitted in the outside hospital. So that time they had done the echo and the blood culture. Blood culture they got this particular Pseudomonas fluorescens outside fluorescence from the blood culture, but it was surprising that trimethoprim sulfamethoxazole they are showing as sensitive. So Pseudomonas isolate it should be intrinsically resistant to cotrimoxazole. For this case it was mismanaged from outside. Why? Because that treating physician from 2024 December she is taking double strength cotrimoxazole daily. Initially it was given as daily, then they changed they are telling to take in between day you have to take cotrimoxazole for prophylaxis. So this patient now presented with bicytopenia. This is a complication of cotrimoxazole only. Bicytopenia, PU under evaluation. Now also that prostatic valve is there. So we are thinking about any prostatic valve infective endocarditis in this case. In our hospital also they have done, the patient is having, you can see the fever spikes is also there. So the patient blood culture also sent and the echo was also done, thoracic echo was done which shows no vegetation. But now also trivial MR and AR is there and the prostatic valve is there. During auscultation that click is also only there. There is no new onset of murmur clinically also. So this case yesterday evening the blood culture got flagged. We have got gram-negative bacilli. So today we have to continue with that investigation. But now Priya is telling it is non-lactose fermenting isolate which is oxidase positive. We have to do the other biochemical test and we have to find out, because previously also 2 years back one gram-negative bacilli in blood with a prostatic valve is there. We don't know whether it is due to improperly treated valve or any other focus is it, because he is having multiple fever spikes for the last 4 months. That part we have to have a clear idea, because it's this report is actually, it's a very bad report from outside hospital. But because isolate is intrinsically resistant also, they are reporting as sensitive and the treating physician is continuously giving cotrimoxazole for this patient.
So it is probably the wrong identification also could be one of the reasons.
Yes, sir.
It has come as oxidase positive.
Yes.
So we'll put up the multitude.
Yes. So currently this patient is not on any antibiotics. They are on acetram as a prophylaxis after this prosthetic valve replacement and other medication, cardiovascular part medication only.
But continue to have fever spikes.
Yes sir, continue. They are
This is medicine department.
Yes sir, it is medicine ward sir. So we informed them, we got gram-negative bacilli. Today we have to follow up this case. This is a recent guideline of prosthetic valve infected endocarditis. Mainly most important causative agent we know it is MSSA or MRSA. So we have to add rifampicin and aminoglycoside based regimen. Whether it is MSSA we have to add cloxacillin or MRSA we have to add vancomycin, rifampicin, gentamicin. The treatment period will also vary. It will be more than 6 weeks we have to give. In other native valve we have to generally give in 4 weeks duration. So it is a gram-negative bacilli, the entire treatment regimen will change. If it is pseudomonas, we have to give ceftazidime based therapy with along with gentamicin we have to give because a biofilm forming agent and all that kind of things. The any surgical management is also we have to look for in that case of infective endocarditis. This is the last case. The patient, 55-year-old male, presented initially to the surgery casualty with upper abdominal pain because he had a history of taking alcohol, chronic alcohol. Last week Sunday also he had taken about 180 ml of alcohol. So he had severe features and clinically it was suspected to have pancreatitis, acute pancreatitis. Outside hospital USG was also suggestive of features of acute pancreatitis. So initially managed by the surgery people. When the patient is having fever spikes, vomiting, loose stools and the bilirubin level was slightly elevated. But here the serum amylase, lipase, everything is in normal limit only within 30 or 20 like that. So there the surgical part they have cleared and shifted patient to the medicine part. So they have done all this tropical fever panel, everything they have done. You can see the total count is only 7,000. The patient is having fever, they are thinking about any tropical illness, dengue, leptospira, malaria and all the other things they have sent. Is under evaluation. Yesterday also this patient we got gram-negative bacilli from a single blood culture bottle. So we informed them currently the patient is on doxycycline and meropenem, because he is having higher risk because alcoholic patient initially suspected pancreatitis and tropical fever panel coverage they are giving doxycycline for this case. So I have to follow up today whether the GNB it is relevant or not. We have to have a look in this case.
Case 6 and case 7 you have to follow up.
Yes.
Okay, thank you.
Thank you sir.